All right, let's jump right into a topic that is absolutely essential for anyone in a clinical setting, especially in psychiatry. We're going to walk through 20 key things every trainee needs to know about domestic violence, pulling our insights straight from cornerstone texts like the Oxford Handbook of Psychiatry, Kaplan and Sadock, and of course the DSM-5. So let's get into it.
You know, these numbers are just staggering. Domestic violence isn't some side issue. It's a full-blown epidemic hiding in plain sight, with really profound psychiatric consequences. So for us, as clinicians, the real question isn't if you'll see this in your patients, it's how ready are you to spot it and respond when you do.
So, to really get a handle on this, we're going to break it down into 4 parts. First, we'll get super clear on what we're actually defining as violence. Then, we'll look at the alarming scale of the problem. After that, we'll dive into the deep psychological scars it leaves behind. And finally, we'll talk about our duty as clinicians when we encounter it. Okay, so let's start with the basics. Because in a clinical setting, you can't be vague. We need precise definitions, the kind laid out in our diagnostic manuals, so we can accurately identify what's going on. Our first 5 points are all about getting that definition right. Okay, so we've got our first 2 facts right here. Number 1, the clinical definition of physical violence isn't just about what happened, but also the potential for harm or fear. That's a huge distinction. And number 2, that little note at the bottom is key. For current diagnosis, the DSM says it has to have happened within the last year. That helps us separate current abuse from a past history. Fact number 3 is about sexual violence, and it all hinges on consent. The keywords here are forced or coerced. It also includes situations where a partner just isn't able to consent, maybe due to being intoxicated, having a disability, or being paralyzed by fear. And again, that 1-year time frame is what we use for coding it as a current issue. And here we have point number 4. This is often the most hidden, most insidious type of abuse. It doesn't leave physical marks, right? But its potential to cause major psychological harm is just immense. It's really all about control, about degrading someone and creating this constant state of fear. And this really shows you what that looks like in the real world. We're not just talking about arguments, we're talking about a pattern of behavior. Things like isolating a person from their support system, taking away their financial independence, or that classic gaslighting. Literally trying to make someone believe they're losing their mind. Seeing these patterns is an absolutely crucial clinical skill. And for our 5th and final point on definitions, it's a simple but vital reminder. While we often think of intimate partners, we have to remember that abuse and neglect can come from other family members, caregivers, you name it. We've got to keep our clinical lens wide enough to see the whole picture. All right, let's shift gears to our second section and our next 5 facts. Now that we have the definitions down, let's look at the numbers. Let's really try to understand just how massive this crisis is. Fact number 6, and this one is just, wow. 1 in 4. Just let that sink in for a second. 1 out of every 4 women will experience domestic violence at some point in her life. This isn't rare. It's a tragically common reality we're going to see in our clinics. For our 7th fact, look at how this private trauma connects to a huge public issue. A full quarter of all violent crime is domestic violence. And what's really important, as the source material points out, is that this is almost certainly a massive underestimate because so much of it goes unreported. And fact number 8 brings it right back to our work in the most serious way possible. In up to a quarter of all suicide attempts, domestic violence is right there as a potential contributing factor. This really elevates our job from just assessing the situation to, potentially life-saving intervention. 9th, while we know this affects everyone, the data shows a pretty stark gender divide. Women make up about 70% of the victims. Now that doesn't at all diminish the very real experience of male victims, but it does highlight a gendered pattern to this problem that we have to understand.
And fact number 10, this isn't just about minor fights. This violence is often incredibly severe. In more than 1 out of every 10 cases, we're talking about serious physical injuries, broken bones, loss of consciousness, things that demand immediate medical care and can leave lasting physical damage.
So, that physical trauma often goes hand in hand with these deep, complicated psychological wounds. In this 3rd section, our next 5 facts are going to explore the direct psychiatric fallout and the other conditions that so often come along with abuse.
So facts 11 and 12 are all about PTSD. Number 11, the kind of deliberate, person-to-person violence we see in these cases is one of the biggest drivers for developing PTSD. It's the betrayal of trust,
the violation of safety in your own home that is so deeply traumatizing. And number 12, even something like stalking on its own can create that same clinical picture of PTSD.
For our 13th point, when the trauma becomes too much to bear, the mind can just check out. It disconnects as a way to survive. This slide shows two common ways this happens. Depersonalization is that bizarre, out-of-body feeling, like you're watching a movie of your own life. And then there's amnesia, where there are literal gaps in memory for what happened. It's the mind's way of protecting itself.
Fact 14, in the most extreme cases, that mental fragmentation can lead to dissociative identity disorder. And the research is crystal clear on this. DID is almost always rooted in a history of severe, repeated trauma, very often starting in childhood. It's really a testament to the mind's incredible, desperate attempt to survive the unsurvivable.
And point 15 really drives home the long-term impact. When abuse happens to a child, it can completely derail their development. It can set them on a path toward a whole host of psychiatric disorders later on. This list here, this is the common tragic result, from PTSD and personality disorders to depression and using substances just to numb the pain.
Okay, so given everything we've just talked about, what's our responsibility? What's our job? This last section is all about action. It's our final 5 facts, focusing on what we absolutely have to do when we suspect or confirm abuse is happening.
Facts 16 and 17 are about the kids. 16, our assessment has to include them because an unbelievable 75% of the time, children are right there, witnessing the violence. And 17, this is not a passive thing. Witnessing this kind of violence is its own form of trauma, and it's strongly linked to aggression and mood disorders in that child later on.
Fact 18 is a really heavy one. It's the ethical principle known as the duty to warn. Look, patient confidentiality is sacred, we all know that, but it's not absolute. If you assess a serious, credible risk of violence to someone else, your duty of care can actually require you to break that confidentiality to protect the potential victim. That's a really tough judgment call you have to be ready to make.
And for our last 2 points, let's talk about documentation. 19, using the right DSM-5 codes isn't just paperwork, it's a critical clinical action. It formalizes what's happening. And here's what's so powerful, and this is our 20th and final fact. The DSM-5 gives us the tools to be incredibly specific. There are codes for the victim, for the perpetrator, and even for a personal history of abuse, which makes sure it stays on the clinical radar for good.
So, we've walked through the 20 essentials, from the definitions and the massive scale of the problem, to the deep psychological scars and our absolute duty as clinicians. But knowing all this is just the first step. The real test comes when that patient is sitting in the room with you. This information is your toolkit. So the question I'll leave you with is, what are you going to do with it? What will you choose not to miss? Thanks for joining me for this really important discussion.